I think it was even okay even if I didn't speak, because most of my interesting cases has already been covered by previous speakers, because my experience with NIDAC is only last 3 to 4 months, and many cases I don't have even proper longitudinal follow-ups of these cases. And I don't have an OCT of Mirande, so I use most of the pictures used in my OCT. No, this is not the presentation. Dr. Prakash.
I think it's my duty to introduce Dr. Prakash. He's a prolific VR surgeon from the northern part of Kerala, and he has a wide experience in managing these type of diseases. Over to you, Prakash.
Thank you, Shane. So with that, my job is actually, So I start with the first case. This was a 17-year-old boy who is on danazol for aplastic anemia. He came with diminution of vision in his left eye. This is his right eye, which is perfectly normal. And if you look at the left eye, you can see that there is some kind of granular material between the disc and macula with hemorrhages along the edge of the lesion. And the wide field photo, actually there are some artifacts in this photo, but actually there is no other lesion in the periphery, only that posterior pole deletion between the disc and macula is seen. And an FAF picture clearly shows granular hyperfluorescence between disc and macula and blocked fluorescence due to the hemorrhage at the corresponding to the hemorrhages on the retina. And if you look at the OCT, you can see that there is an active portion of the lesion, a retinitis. It's a retinitis lesion, and the active portion is a full thickness retinitis, which is casting a shadow behind, and there is the classically described as a cavernous type of outer layer defect that is very characteristic of CMV retinitis. And here the healing lesions show early atrophic changes. There is a granularity of the inner retina, and there is a drill change, disorganization of inner retinal layers setting in, and the retina is going down, subsiding, with an ILM getting detached from it. The ILM is fairly reasonably preserved, and you can see the vitreous exudates overlying the underneath the ILM as well as in the vitreous cavity. So these features are what is typically described for CMV retinitis. Basically here it is not the fundus photo but the OCT which clinches the diagnosis of CMV retinitis, and this patient was treated with intravitreal ganciclovir with good response and healing of the lesion. And the healing pattern also is very interesting in these cases. You can see that there is a full thickness atrophy of the retina which was affected by the CMV retinitis, and the ILM is separated, the rest of the retina appears subsided down. So this is a second case where a 38-year-old male came with floaters in his left eye. Both eye he has 6/6 and 6 vision. The fundus photo of the right eye shows the periphery, you can see almost till aura. There are peripheral sclerosed vessels and corresponding angiography shows extensive CNP areas in the periphery. There are multiple neovascularization, neovascular fonts, shunt vessels in the periphery, and you can see the whole extent of CNP areas very clearly. Similarly, in the right eye, which had a mild vitreous hemorrhage which was causing the floaters, here also you can see the angiography clearly shows the capillary non-perfusion areas as well as the neovascularization. So we could do a well-guided photocoagulation to the periphery, the peripheral CNP areas for this patient, so that the new vessels regressed well post-treatment. So case 3 was an interesting case, 48-year-old female who came to us some kind of visual disturbance in her left eye, but vision is 6/6 and 6, and the fundus photo, the wide angle photo shows some kind of elevation along in a circumferential pattern along the equatorial area. You can see that lesion there very clearly. This is the other eye which is perfectly normal. Here an ICG FFA was done, but this was done in a Heidelberg machine. Here you can see there is some kind of hyperfluorescence in the early phase both on ICG as well as FFA, and late there is increase in hyperfluorescence, but on ICG you can see corresponding to those placoid lesions, you can see blocked fluorescence on the ICG, which tells you that the lesions are at a deeper level, sub-RPE probably, and OCT clearly tells us the lesion where exactly it is located. It's under the RPE close to the disc at the posterior pole, and if you look at those, take scans along the equatorial area, you can see the bumpy RP. The RP is bumpy and there is some material underneath the RP, and between the RP and sensory retina also you can see some exudative material. So these findings, especially this OCT as well as with this kind of picture, it's a very clear-cut case of primary intraocular lymphoma, and this patient underwent a vitreous biopsy as well as I took subretinal biopsy also, did a retinotomy along that area above the arcade and took the subretinal material, and endolaser and C3F8 was injected, and at the same time we had given injection rituximab by this patient. This is a post-op photograph where you can see that there is a large RP drip. Most of the lesions actually resolved very well, but the large spontaneous RP rip developed inferiorly, that is not at the area where the retinotomy was made, but exactly inferiorly in opposite direction. And the biopsy turned out to be positive for primary vitreoretinal lymphoma. This patient was managed with multiple injections of rituximab and methotrexate. This is the OCT which shows the response of the lesion immediately post-injection. And here at the superior area where we initially saw the multiple RP bumpy areas, you can see that RP has become flattened now. And you can see my area of retinotomy also which was made during the surgery for the subretinal biopsy. But unfortunately, after the third injection, patient did actually very well, but after the third injection, patient came with sudden drop of vision. Now I can see a vascular occlusion. There is cattle trucking of vessels inside in the retina. I don't know whether it was due to infiltration. We could see some cells also in the vessels. Whether it was infiltration of lymphoma cells into the vessel or it was due to the injection, I couldn't tell, but the vision dropped for the patient. This patient was started on systemic steroids and vision gradually improved to around 2/60 in later period. So this patient is currently on treatment. So systemic rituximab also has been started. This is the fourth case, which is a 60-year-old man who came with the gradual diminution of vision in right eye, diagnosed as CRAO elsewhere. When we did an angiography, you can see that there is extensive, even in the late phases, there is no filling of vessels, only there is some vessels around the disc, but rest of it completely occluded vessels. There is a total non-perfusion of the retina, and this patient on MR angiography showed a complete occlusion of the carotid system. This other eye which shows mild NPDR only. The case number 5, where a 47-year-old female who had history of breast cancer was on treatment, came with some vague visual complaints in her right eye, and you can see on the fundus photograph there is an elevated lesion along the superior arcade just above the disc, and on an angiography you can see there is granular hyperfluorescence in the early phase which is leaking in late phases, and that's a wide angle angiography which shows the lesion clearly. There are no other, except for a small hyperfluorescent spot here, there are no other lesions seen, and ICG shows the intrinsic vascularity of this lesion, and when a PET scan was done, there was multiple spinal mets also for this lady, and this lady was referred for palliative care. So that's the OCT of the same lesion, of the metastatic lesion in the choroid. Deep in the choroid you can see the elevation and total full thickness choroidal involvement. This was another case. It's already been, we have seen many of these cases actually. This is a 69-year-old lady who was referred as melanoma because of a brownish lesion in the periphery, and that's a peripheral. When you tilt the eye a bit, you can see almost till the aura, and you can see a large pigmented lesion here with a lot of exudates surrounding it. This is nothing but a sub-RP bleed in the periphery, and the fluorescein angiography, wide angle angiography shows multiple RP defects in the periphery, and in the late phases you can clearly see the PED with a little pooling inside, and the ICG, wide angle ICG, clearly shows the peripheral polyp. So this is a case of peripheral exudative hemorrhagic chorioretinopathy which was treated with the peripheral laser to the lesions with good resolution of all the lesions. That's a OCT, peripheral OCT through that particular lesion. And this was a 25-year-old male who was referred for to rule out ATT toxicity because he was giving some visual symptoms. Actually, he didn't have ATT toxicity. He had 6/6 and 6 vision both eye. But what we saw was on the fundus photograph, you can see there were some small yellow dots, yellow lesion, deep lesions. It is not. Yeah, just here you can see the small yellow lesions, which was not very well defined on the wide angle photo. But we did an angiography, fluorescein angiography, and ICG. Angiography didn't pick up the lesions well, but on ICG you can see there is a full thickness, multiple lesions in the deep choroidal level, which are persisting even in the late phases, which tells you that it is almost full thickness. So these are the choroidal tubercles which are seen in miliary TB. This was seen in his other eye also. These lesions were clearly seen on the wide angle ICG for him in the other eye also. So he underwent ATT with a good resolution of all these lesions. So this is case number 8, where a 28-year-old female who came with a transient diminution of vision in her right eye. There is a large, disc was swollen, and there is a large area of subretinal hemorrhage below, inferior to the disc. And the fluorescein angiography clearly shows there is a CNVM, peripapillary CNVM, and the blocked fluorescence due to the hemorrhage. So this was a case of peripapillary CNVM. This patient actually on evaluation turned out to have sarcoidosis. She has a peripapillary granuloma with secondary CNVM. So that's all about, I think, the NIDEC wide field imaging is a very useful technique for especially these kind of peripheral exudative chorioretinopathy as well as retinal vasculitis, to get a very good picture of the periphery, which otherwise you wouldn't have treated in many of these cases. Thank you.
Thank you, Prakash, for showing those beautiful cases. You have any doubts, any queries? Be free to answer. Due to lack of time, I think we'll wind up if there are no more queries.